and welcome to tonight's episode of Rural Doctors. I'm Jerry Gannon. Thanks for your company once again. Tonight, the focus of our program is rheumatology. We'll hear from Dr Stephanie Davies, Head of Service of the Pain Medicine Unit, and Melanie Galbraith, physiotherapist from Fremantle Hospital, about back pain. We also speak to the Director of Pain Medicine at Royal Perth Hospital, Dr Stephan Schug, about the management of opiates in treating malignant pain. But before we begin, I wanted to let you know about some special web broadcasts that will soon be available on the Rural Health West website. The first is a program on dermatology featuring Dr Kurt Gebauer, which supplements our February broadcast. And in it, he discusses both benign and malignant skin tumours, including BCC, SCC and melanoma. And the second is a series of discussions between Dr Olga Ward and Dr John Murtagh, in which they discuss all aspects of general practice. Now, all of these programs can be accessed as normal on the Rural Health West website at www.ruralhealthwest.com.au. Well, now to rheumatology. And joining Olga and I on the studio is rheumatologist Dr Andrew Taylor from St John of God. Olga, welcome back again. And Andrew, good to see you here.
Thank you.
Rheumatology. What's the percentage of the population present with some sort of symptoms of rheumatology? Do we know?
Through your lifetime, about 80% of people are likely to get osteoarthritis. Now, whether they have symptoms or not, 80% of people will end up having osteoarthritis. If you talk about back pain, short-lived acute back pain, 30% of people in the last month of adults would have had some form of back pain. Then if you just think about simple joint pain, muscle pains, aches and pains, everyone from day to day has some degree of musculoskeletal pain. So it's very common.
You're not in the minority then, Jerry?
No, I'm not. With me, with my dodgy thumbs.
Well, many patients come to the GP and complain about joints that are stiff and swollen, especially in the morning. How do you work out which patients have inflammatory joint disease and which ones are just kind of overdoing it in their day-to-day life?
Yeah, I mean, it's the key thing, because you want to identify inflammatory arthritis, because it's the disease that you need to identify early and treat early. Because it's a systemic condition, it will damage the joints, it will progress, it will affect other organs. So you're right, you've got to identify that early. And the key thing for most patients is that the pain and the stiffness and swelling is a significant problem to them. And the stiffness is a primary complaint that they have in the morning. And it's usually a new symptom they present with. Maybe over a 6-month period, but it comes on, and often they'll wake up at night with it. So waking, not because they're moving, but waking up because their joints ache is a prominent problem.
Yeah. And you're talking peripheral joints mostly here, because a lot of
it
people wake up with a dicky back.
Yeah, but you can get inflammatory back pain if you're talking about spondylitis, ankylosing spondylitis.
Yeah.
So the key things that differentiate them really is the intensity of the pain and stiffness, that it often wakes them from sleep. It's very intense in the morning, and critically it's something that lasts for more than 20 minutes, half an hour, often several hours. And the thing I always you put to patients is, when do you feel at your best? Appreciate you don't feel good when you wake up in the morning, but how long does it take you to get mobile and get as free as you're going to get? And if they say, by the time I've got up, gone to the bathroom or got out to the kitchen and put the kettle on, then you know that you're unlikely to be dealing with a significant inflammatory problem. But if they say, it takes me till about 10, 11 in the morning before I finally get going, then you think, okay, I'm dealing with an inflammatory joint problem.
So it's the inflammation that causes the problem. As the day progresses and they get better, what exactly happens to them to alleviate their suffering?
It's mainly motion and circulation, so you're losing a lot of the inflammation, the swelling in the joint and the vascular congestion. So the swelling will tend to come down, the joints will start to free up. But what you find in someone who's got a good going inflammatory arthritis, that they'll have that window in the middle of the day, maybe between 10 and 2 when they're reasonably mobile, but then in the afternoon the inflammation starts to set in again and they find that they start getting stiff and sore.
Yeah. So when you're feeling very suspicious that somebody's got an inflammatory joint disease, What would be the initial workup that you would expect to do either in your rheumatology practice or as a GP who's seeing a patient?
If you're suspicious, really, in most cases, 90% of cases you diagnose clinically on a history and examination. And then you'd want to support that really with blood tests to see if there is inflammation there. So if their ESR is elevated and their CRP is elevated. So if both are elevated and you've got a story of an inflammatory arthritis, well, that's pretty clear.
Yep.
You know, if that's supported clinically.
Implications for a patient of allowing this to go untreated. What's the worst case scenario that can happen to them if they just, you know, suck it up, princess, and go through the pain?
Well, the worst case scenario is if you consider, say, rheumatoid arthritis, which is the most common sort of inflammatory arthritis. Rheumatoid arthritis, if it's not diagnosed early and treated early, 80% of people by 10 years will be out of work. And it's got the same life expectancy as triple vessel heart disease.
Okay.
Yeah, so we've increased incidence of cancer, infections, kidney disease, liver disease, you know, just general vascular disease.
Plus all those other, you know, inflammatory lung diseases like fibrosing alveolitis. Does that go along with rheumatoid?
It does, yeah.
Yeah.
So
And I do remember a guy who had a very erosive disease in his neck, and he had to wear a brace while he was sleeping, even in his wheelchair, because his C1, C2 joint was gone and his head would fall off.
Gosh. But
So
if
scary, Jerry.
If treated, what sort of success are we talking about, Andrew? Can you ever cure it, or do you just simply manage it?
No, you can't cure it. The whole thrust now is remission. Early diagnosis, early treatment, and you treat to remission. You don't tolerate any sign of disease, because you know if you do, if there's ongoing disease you're partially treating, then you'll never get on top of the disease, and patients will continue to get damaged joints.
And causes, do we know what causes it, or is it genetic, or do you have to have a genetic predisposition for it?
Well, for rheumatoid, you don't have to, but people are genetically predisposed, and the likely thing is that you have some form of genetic predisposition to autoimmune diseases, and then various incidents and insults through your life, be it infection, smoking, then the various building blocks come into place, the immune system's primed, and then the disease presents. I mean, it's been recognised.
You create the conditions, basically.
Exactly. And smoking's one of the key things. You know, it's been recognised recently that smoking is one of the main risk factors for rheumatoid arthritis.
When we're seeing a patient with inflammatory arthritis, you said to look for inflammatory markers like their ESR and their CRP. How much use of things like rheumatoid factors and anti-nuclear factors and all those other things that we tend to order in a block?
They're important if they're present in someone who's got the disease, but their diagnostic value is limited. You've got to remember these tests are far more prevalent in the general community who are healthy than the disease themselves. So if you take an anti-nuclear factor, 5% of people will have an abnormal result who are healthy. But say lupus is only found in less than 1% of the population, probably 1 in 1,000 people.
Yeah, and I'm seeing quite a lot of patients with what they call seronegative rheumatoid arthritis. So I suppose they've just got the clinical picture without the actual marker?
Without rheumatoid factor, yeah. So it's important. The key thing is diagnosing an inflammatory arthritis. And then you categorise it and you look for prognostic markers and things that will tell you what to expect in that patient. And rheumatoid factor is one of those, CCP antibodies is one of those, anti-nuclear antibodies another one. So they tell you a bit about the expression of the disease, what you can expect from it, and how you treat it. But in diagnosis, they're quite limited.
And I guess in the mozzie season, we go chasing Barmah Forest and Ross River and those as well.
Yep.
Well, hand problems are a really big issue functionally, especially problems with things like grip and flexibility. How do you go about assessing hands?
Primarily, you want to know what you're dealing with.
Yeah.
And if someone presents with pain and stiffness and difficulty with function of the hands, you want to find out really what structure is causing the problem, and then you want to know what process is going on there. Someone may present with a stiff, painful finger or fingers, and the problem's tendon related.
Yeah.
or it could be joint related, it could be nerve related. And the pain they may have may be nerve related and not arising from the joints. So you want to determine where the pain and the function loss is coming from, so what structure is causing that, and then you want to identify what's going on in those particular structures.
Yep.
So, and primarily you're wanting to then identify in those structures, if they're joint structures or tendons, are they inflamed or not, or is this a non-inflammatory or degenerative problem?
Is there any particular red flag with hand symptoms that would make you sit up and take notice straight away?
Really, the things you'd be interested in and worried about acutely is infection.
Yeah.
So if someone presents acutely with a localised problem with intense inflammation, then you'd worry about infection. Otherwise, if someone presents with generalised joint problems, both wrists, all across the MCP joints and finger joints, painful and swollen quite acutely, well then you think of an acute inflammatory arthritis.
And Andrew, what about the joint pattern of inflamed joints in a hand? Does that give you a clue?
It does. Rheumatoid arthritis and those type of inflammatory joint conditions usually tend to be bilateral and symmetrical, affect the wrists and across the MCP joints and PIP joints. One variant of that is psoriatic arthritis, which can affect the DIP joints in association with nail involvement. So if they've got an inflamed DIP joint, they have to have nail disease as well with psoriasis. And psoriatic arthritis tends to skip fingers and can involve an entire finger joint, and you get an entire swelling of a joint, sausage, digit or dactylitis. And then osteoarthritis itself can be inflammatory.
Yep.
And osteoarthritis, in the early stages, you can get a red hot swollen joint, but it typically is the distal joints, the DIP joints and PIP joints. Doesn't act as onset as a symmetric disease. A joint will be affected, then later on another joint and then another joint, and you get this sequential involvement, but it's the distal joints.
I know that psoriatic arthritis really is quite destructive and can move quite fast. Is there a specific test for it?
There's not. No, there's nothing.
So until an X-ray change appears, you're basically making a clinical diagnosis based on nail changes and pattern of inflammation?
Well, yeah, not so. Nail involvement for the type of psoriatic arthritis that involves the DIP joints, so the toes and the fingers, definitely. Otherwise, it's purely clinical. 15% of people with psoriatic arthritis will have the arthritis before skin disease.
Yeah.
So you don't have to have psoriasis. So it's purely clinical on how it looks, how it presents. And the key thing that makes you always think of psoriatic arthritis is if they get a sausage digit, so a whole toe or a whole finger gets swollen and fat, and they're the ones that often present with an inflamed knee, large effusion, 100, 200 mils in a knee, and just a chronically inflamed swollen knee.
Yeah, and then you drain it. What would you see?
That's a good point, because if you can get fluid out from a joint, and you always try to get that, because if you're wanting to diagnose a joint problem, you always try to aspirate the joint. You can identify then whether it's an inflammatory problem or not, whether there's infection there or not, or whether you're dealing with like something like gout or pseudo-gout. So you look for crystals. So you always try, if you can get the fluid off, you send it off to get a white cell count done on it.
Yeah.
And for microscopy, so they can look for infection or look for crystals.
Yep. I know years ago when I was doing rheumatology, we had to put some fluid in a yellow top jar and then some additional fluid in an EDTA tube for the cell count.
That's
Is that
right.
still the process? And of course, now that there's no rebate for joint injection and joint drainage, how are you finding that affects people's practice?
Well, it shouldn't. I mean, it's...
So you would mostly use them for making a diagnosis or for making a patient comfortable.
And for treatment. I mean, the rebate was ridiculously small anyway.
Yeah.
So it doesn't stop you doing the procedure. It's just then a matter of whether you charge the patient or not and what you charge the patient.
Yep.
If something's necessary, you still do it, whether there's a rebate for it or not.
And the necessity is diagnostic and treatment.
That's right. It's both diagnosis and therapy.
Yeah. While we're talking about joint injections, just quickly, if a joint happened to be infected and you'd made a wrong call and kind of looked at this fairly clear fluid and decided that you thought, well, it was mostly inflammatory and you put some steroid in there, are you in really deep doo-doo? Have you really done the patient a lot of harm?
No, I mean, there's some evidence to suggest that in the short term you're actually doing them a favour. You're aspirating the joint, and the bit of cortisone you put in will lessen the destructive inflammatory response. You get the diagnosis of infection either later that day on microscopy or on culture later. You haven't lost any grounds at all. So it's really not the crisis that people think it is.
Super. And when you do have a very inflamed joint that you've drained and it's infected, are intravenous antibiotics mandatory?
Depends on the infection, but usually. So usually you've got to look at intravenous antibiotics for 2 weeks.
So you'd pop them in the local hospital and wallop them full of high doses of whatever the bug happened to be.
That's right, yeah.
Suggesting you used.
Yep, do that, and then you've got to follow on usually for 4 weeks after then with oral antibiotics.
Are there different kinds of infections that these joints are susceptible to, Andrew?
It depends on what disease someone has. If someone's got normal joints and they get an infection in a joint, then it's usually the common skin-related infections that you get. If someone's got other illnesses, then they may have kidney disease or bowel disease or lung disease, then they're predisposed to additional infections, so they may get into the joints. If they've got an underlying arthritis, other conditions, and their immune system's being suppressed by the medications that they're on, then again they're open to a different range of infections that you don't normally see. And they can be the tricky ones because they may be ones that are quite indolent and very slowly progressive, and that you don't tend to think of them up front. And they can be hard to find. Need special cultures and things to identify.
And that looks like a good time to get into our first segment. Back pain is one of the most frequent musculoskeletal conditions seen in general practice, and the severity and debilitating effects of acute back pain hits everyone differently. Dr Stephanie Davies and the pain team from Fremantle Hospital provide pain education sessions for both patients and health professionals. Over the coming months, they'll be taking their education sessions to a number of regional centres, and these workshops are highly recommended. We spoke to Stephanie and physiotherapist Melanie Galbraith about pain and their workshops.
Hey, Stephanie and Mel, welcome to the program.
Thank you.
Now, back pain is a very, very common presentation in general practice.
Yeah.
Could you tell me a little bit about the spinal pain workshop that you're taking around as a rural roadshow?
We'd love to. Essentially, we're going to go to 3 different places over the next 12 months, Kununurra, Albany and Kalgoorlie. We're going to have 1 day for health professionals, which is aimed at getting GPs as well as other health professionals like OTs, physios, and if there's any clinical psychologists in the region together. And we just essentially have a program we ran last year, which has already got 40 CMU accreditation points, which is a bit of a winner, which we're going to basically take a selection of the health professionals from Fremantle, including our physiotherapists, clinical psychologists and pain medicine doctors, to actually run that day in those locations for like a 6.5 hours on a Saturday. Then on the Sunday, it's more of a consumer day, so it's more aimed at people who have persistent pain in those different locations, or if they're close enough where they can come into one of those 3 locations. And essentially we're going to be doing within a 6.5 hour window what we normally take about 8 hours to do in Perth, but we have decided that trying to at least do contain it all within 6 hours is possibly more doable for people to come than if it was an 8 hour single day, which would be a lot for somebody in pain.
Sounds like a crash course in a whole pain medicine team. How does the whole team thing work now?
Well, this is currently what we're presenting in Perth, as Steph said, over 2 days. So each of the health professionals has a different role, and we're basically delivering information, upskilling patients on their self-management. And we find that a lot of the patients that attend the course in Perth are able to manage their pain without any further intervention. So for example, I'm a physio, and from our point of view, some patients may have tried exercising and started off doing too much too soon and increasing too quickly, and just fine-tuning that a little bit and knowing how to gradually increase what they're doing without flaring up their pain, they're then able to improve their function.
A lot of what we're taught, either through the press or the media or when we're at med school or different professional groups, haven't actually told us that pain actually is not easy to solve. They haven't actually told us that the things that we do to people don't always help them. And there's a lot of disbelief out there where people are disbelieved because you can't see pain like on x-rays or on people. And we have to actually totally turn that upside down and just let people know you can't see pain on x-rays and you can't see pain on people. And the first thing you have to believe that people are in pain if they tell you, and they're trying to treat it. You have to step outside of just the traditional medical model, which has probably not been helpful for a lot of people in pain. Mm-hmm. So say if there's 8 or 9 or 10 different things any person could do to help manage their pain, basically, sadly, we can't give all that information in 10 minutes or even half an hour. So it takes that time to give them a bit of context, but also to give them an idea of what different things they can do in their own self-management. All of that is still often in conjunction with medical options that they might access for their GP or the physiotherapist, but just giving them the idea of the broad range of options, and then they can select out of those things which things they think that they want to do.
How do you follow that up with the patients?
We're in Perth. The main point of call after they've come to our 2-day program is if they need more one-to-one help from us versus accessing through the GP or the local physiotherapists, they'll just phone and ask. Mm-hmm. But we also send out paper questionnaires at 3, 6 and 12 months. That portion will be doing very similarly for the people who come to the consumer workshop on the Sunday. Also for the people who live remote and rural, they may well try to access their care closer to home through their GP or their physio. If they need to access, then they've also got the possibility of using either coming down and seeing us face-to-face or actually using telehealth, which we've now thankfully got machines to do for both individual consultations as well as within our group program.
So the potential is that, say, the GP and the patient, or perhaps the GP and the physio and the patient, or the physio and the patient, could sit in the telecentre in Moonooka or Halls Creek or somewhere and access a video conferencing consultation with the whole service, or does it just happen with one person?
Currently, as of it'll probably be just the individual consultations will just probably be one person at a time, although we're going to have both our clinical psychologist and our pain medicine consultant who will be doing that, predominantly because where we normally have our clinics where we all see the patient one after the other doesn't actually have webcams or telehealth equipment as yet. Having said that, we've got a business case in to get some very simple web cameras which are not expensive, but it's more of an organisational issue rather than a issue that we don't think is a good idea. It's just trying to do the organisational part. So
one can see the potential for this being a whole team management for these extended primary care items for these patients. Mel, do the physiotherapists and the other allied health professionals actually educate everybody in the professional day, or do you just have specific sessions just for physios?
We find that the information that we put across is, applicable for everyone to know. Yeah, so we're looking at overall management for sure.
There's a new catchphrase out in Healthland, which is interprofessional learning. Yeah. And what's been out for a decade or 2 decades before that is multidisciplinary care. Yeah. And you sort of think, well, what's the difference? Is it just a new word to describe it? But if there is a difference, it's probably an interprofessional learning. Essentially, I aim to know quite a lot of physiotherapy. I aim to know quite a lot of what clinical psychologists do, but I don't actually want to be a physio necessarily or a clinical psychologist, but I actually get to understand what it is they're trying to achieve with a patient, just as they try to understand what I might be trying to achieve as a doctor. So we don't have to do each other's jobs, but it's so that if a patient discusses with me what the physio is doing, I can actually say, well, does that look like reasonable care? Does that actually look like a reasonable skill set that they're teaching? Or is this actually not actually anything close to what I thought the patient would be receiving if they go and see a physiotherapist or an OT or a clinical psychologist? Mm-hmm. Possibly slightly different. Multi-dis in my brain sometimes is a bit too much in silos. So you refer them off to the clinical psychologist or the physio, but you never actually ask what they're doing. interprofessional is more everybody sort of working together as a team. Doesn't mean we need to do each other's jobs, but just having really quite a good understanding of it.
How do the GPs, particularly since they're the people we're broadcasting to at the moment, how do they access this workshop?
The organisational for the Saturday, which is the Health Professional Day, is going to be organised through Rural Health West, who are very efficient at organising these programs. They helped us, not last year, the year before. Very efficient, very good, very thorough. So just contact Rural Health West. For the patient side, that's going to be organised through Arthritis WA. They'll be sort of taking names and contact lists.
And do GPs need a special interest or a pre-workshop or
No,
any particular skills to come into this?
No, they don't actually need anything. And at the risk of sounding sadomasochistic, what I'm going to say is actually the pain days are really fun. There was a whole lot of aha moments, things that were never taught in med school. So just as we say the patient days, we tell the patients all the secrets. Well, on the health professional day, we tell them all the secrets, all the things we just didn't know or weren't taught or wasn't seen as a priority when we went through med school. So GP is highly relevant. I think physios and clin psychs have a bit more of an idea than we might have.
And the allied health professionals in our towns will also be duly informed of this workshop?
Yes, we can certainly let them know through the APA. Yeah.
So it'll be through the professional organisation.
Fantastic. And the very last thing, when are the workshops happening?
Well, pre-written on my hand. In Kununurra is August the 7th and the 8th. Albany is November the 27th and the 28th. And the one in Kalgoorlie is going to be February next year. I don't think we've actually formally done the dates for that one yet.
Fantastic. Well, we'll get the doctors to check the Rural Health West website for any updates on that.
Thank you very much.
Thanks for joining us.
And thank you to Stephanie and Melanie. Now back to our discussion with Andrew Taylor. Olga?
Well, since we've got our minds on back pain, Andrew, I'm seeing a lot of patients, and many of my GP colleagues also comment on this, with ankylosing spondylitis, and particularly women. Is it on the increase, or have we just got better tests for diagnosing it, or are we just more suspicious?
I think more suspicious.
Because not all of them are B27 positive either.
Most should be.
Most should be, and most are.
Yeah. It's more a case of suspicion and recognition. And in the past, it used to be thought it was 9 times more common in men than women. And that's, I always like to tell my female patients because they don't complain as much. And that was the reason for it. But it's about 2.5 times more common in men than women. So it's being recognised more in women, and people are thinking about it. And you can diagnose it earlier with MRI, but ultimately they'll present with X-ray changes. But with MRI you can diagnose it earlier. But I think now that there are effective treatments and you can do something about the disease, it's being thought about, and I think that's why it's being recognised more.
Now, effective treatment used to always be anti-inflammatories, prone lying with hot packs and exercise. Anything new?
The anti-TNF agents, the biologic agents. They're just fabulous.
So which agents are you speaking about there?
Etanercept or Enbrel.
Yep.
Adalimumab or Humira.
Yep.
Infliximab or Remicade. Golimumab or Simponi.
So these are the similar kinds of drugs that you use for other inflammatory
for rheumatoid arthritis
well.
or psoriatic arthritis, And
how do they work?
Well, they're antibodies designed to purely block tumour necrosis factor.
Yeah.
And we know that's one of the key cytokines that drive the inflammation and the inflammatory response. So steroids and whether it's methotrexate or other medications, part of what they do is partially suppress TNF. But these antibodies will just block TNF and prevent it acting and prevent this cascade of inflammation. So it will do just what you want it to do.
Now, they sound like something that GPs don't often prescribe. Is that an initial prescription from a specialist or a continuing specialist thing? Or
they can only be prescribed by rheumatologists. And
so we would be getting our patients off a bit earlier if we were expecting that they would need such a thing?
Oh, yeah.
And do they need very advanced disease before they qualify for this type of drug? Do they have to go through all the simple options first?
Oh, they have to. If you take say, rheumatoid arthritis or psoriatic arthritis, if someone presents within 6 or 9 months, you can have them on an anti-TNF agent.
Mm-hmm.
The thrust now really is early treatment, early intervention, and identifying patients early who have aggressive disease that isn't going to respond well to, the conventional treatments that we all know. And you try to get those patients on the anti-TNF agents early. So that's why early diagnosis, early referral, and early treatment is essential. So in some patients with acute severe rheumatoid, within 12 months you may have them on one of these agents. With ankylosing spondylitis, as the requirements stand at the moment, they have to have established disease where there's X-ray damage before you can get them onto it. So that's usually further down the track.
It's a little bit like the preventing osteoporosis after the fractures happened.
Exactly. That's exactly right. Yes. So it's a problem. You've got to wait for them to be damaged before you can give them treatment. Hopefully that'll change down the track. That's just the way things stand now.
Mm. Andrew, with the extended primary care items that have come in and become extremely popular over the last few years, what sort of team role do you see for the rheumatologist in conjunction or being kind of over-managed by the GP with the country physios and OTs? How does it all work together, and how does the information get gelled?
Yeah, I mean, rheumatology was the initial discipline that developed multidisciplinary care.
Yep.
Because it's so important. So coordination is necessary because most patients will be relying on the care from their GP, coordinating with physiotherapists, podiatrists, occupational therapists to get the care that they need. So you may initially, through the diagnosis, recommend to a GP that this is what's required, they need to see these people and get this particular form of allied health care.
Yep. So the splinting and the working and stretching are all still just as important as they ever were.
Absolutely, yeah. Yep.
So does diet play any sort of role at all, Andrew, in the management of these conditions?
Oh, it's important for someone's general health, diet. It's important to maintain an ideal weight. To directly influence what someone feels, it doesn't play any part. No.
Yeah.
But it's more general well-being, appropriate diet, you're healthier, your immune system's healthier, you can deal with your chronic illness better, and then of course maintaining an ideal weight.
Now I'm going to ask that question, Olga. The use of things like glucosamine or chondroitin, do they actually work at all?
Well, they're proven not to modify the joints, not all the claims about preventing osteoarthritis, deteriorating, preserving joints, healing cartilage, that sort of thing. It's all nonsense. It's been proven not to be the case. At best, they've got a mild analgesic effect, at best, but no better than paracetamol.
Really?
Yeah. So all of these claims have been disproven.
And shark cartilage, remember that fad that was around with shark cartilage?
Sharks don't get arthritis.
Yeah.
I mean,
but then all of their joints are beautifully supported in water.
Exactly, the advantage of hydrotherapy. That's right. But the thing is, for arthritis, anyone with joint problems, you've got a 30% placebo response. So if you were going to look at an area where you wanted to invest and make money, you'd come up with some treatment for arthritis. Because you know that you can invent something that doesn't have to work, but you'll get a 30% response in. So you've got a huge market out there to sell something that you'll get a response from in 30% of people.
What about those anti-inflammatory gels like Nurofen gel and Voltaren gel? I'm sorry to mention brands, but they're the common ones.
Yeah, no,
do they actually absorb into the joint?
They do, they work. I mean, they've been shown with osteoarthritis of the knee to help with pain and movement and stiffness. And certainly other superficial joints, hands particularly, or if someone's got muscle problems, they certainly help.
And Alcucel. Do you remember Alcucel? Does that work?
Or salicylic acid.
Yeah.
It's aspirin.
It's aspirin. It's an anti-inflammatory. That's what you get in all of these topical liniments.
Yeah.
So, it does help.
Yeah. Now, speaking of things that are influenced by diet, what's the latest on gout?
The latest really is in therapies, which unfortunately don't have available yet, but there are new therapies coming out to treat those patients who you can't treat with allopurinol.
Yep.
particularly because they might have renal disease or be allergic to it. So there are new treatments on the horizon for those patients who are the really difficult gouts that you can't treat. In most patients with gout, I think the recognition is the relative importance of diet, which mustn't be forgotten. So you've got to, patients need to stick to a low purine diet. They need to reduce
more
alcohol.
oysters and red plonk, yeah.
Yep, those things.
Well, they used to call it a rich man's disease, didn't they? In the old days.
Because only people who could afford those.
Exactly.
That's right. But gout, you still see a lot of gout and a lot of poorly treated gout. And the key message I have for GPs is that there's this myth around that you can't start treatment with allopurinol until they're free of attacks. You'll never get anywhere. They'll just keep getting attacks and you never treat them.
I was going to ask about that initiation of treatment, particularly because at the moment I have a patient with incredibly resistant gout, which we can just about get under control with anti-inflammatories. Can one then start the anti-inflammatory while their joints are still grumbling?
From day one. Yep.
So
you start
that
treatment
allopurinol straight away
Yep.
at low dose and creep it up?
Yep.
So over what period of time would you get that going?
If someone presents with gout and you recognise that they need to be treated, and really that's every patient. I mean, I'll put to a patient, you've had your first attack of gout, do you want another one? And you know they will. So in everybody you treat, in the past it used to be thought, oh, well, if they've had 2 or 3 attacks, then you start treatment.
Yep.
I mean, I don't see any sense in that. So you start treating straight away. And I will treat with allopurinol straight away. If they've got an attack, you're treating that inflammation. You know that if you initiate allopurinol, you're going to mobilise the uric acid stores, so they may then get attacks. So you treat that. You have ongoing anti-inflammatory therapy and sometimes prednisolone regularly to control their disease. And then you gradually step up the allopurinol so you get their uric acid below 0.3 and keep it there. If someone's old and they've got renal disease, then you're a bit slower and more cautious in increasing their allopurinol dose.
But you do this over a couple of months, yeah?
Yeah.
And what's the maximum dose that you can go to?
Oh, I've got patients on 900 milligrams.
Oh, okay, so 300, despite the fact that it's the big tablet, isn't the ceiling of the dose. You can actually push it higher.
That's right. And sometimes you might give them probenecid as well.
Yeah, I was going to say, does that still have a role?
Oh, yeah, yep. So if someone's got reasonably functioning kidneys and you can't control their disease or get the uric acid low enough with allopurinol alone, then you can give them probenecid. Vitamin C as well is also uricosuric, so that can lower their uric acid. And the other thing on diet, the key thing to recommend to people you don't tend to think of is soft drinks. Yeah. I mean, fructose raises uric acid. A lot of people drink a lot of Coke and other soft drinks.
Poisons.
And they think that they're doing okay because they're on the diet soft drink, so it's not going to put weight on.
Exactly. Andrew, what about exercise in the management of these? Does it do harm? Does it do good? What's the conventional wisdom?
Oh, exercise is vital for everybody. Yeah. In some settings, in specific settings, you may recommend to a patient that they need to rest a particular joint or region for a period of time. But generally, for most patients, it's exercise. And the key things for people is you've got to maintain flexibility. That's very important. You've got to maintain strength of a joint and its range of movement, whether it's the spine you're talking about or the limb joints.
What about massage therapy as a complementary? Does that help?
Oh, it feels good.
Makes them feel right, yeah.
It always feels good.
Yeah. I mean, it can be a part of things. But a lot of people, whether you're talking about back pain or other joint problems, you're treating the tight muscles, the sore muscles, but you're not treating the cause. And whether it's a back problem or another joint problem, you've got to treat what's causing the tight muscles and the stiffness.
Now, you guys have rattled off an amazing list of drugs to treat these conditions.
Yes, and I've got some more that I want to ask about as well, Jerry.
And I'm sure some of these have got side effects.
Yeah, and I was going to ask about colchicine, which is noxious stuff that knocks off your kidneys and gives you horrible diarrhea. Do they still use that for gout?
If you use it that way. I mean, the old treatment line of 2 2 colchicine tablets and every hour, 2 hours keep them, that's just reaching toxicity and just poisoning people. I use a lot of colchicine. I'll use 1 or 2 tablets a day in people with gout. Also, if people have other inflammatory joint problems, it's an anti-inflammatory agent. It can work really well if they can't take NSAIDs.
Yep.
So I certainly use colchicine. It's a great drug.
Better than a COX-2, if they can't take a non-steroidal?
In gout, yeah.
Yep.
Because it primarily works on the neutrophils, which are responding to the crystals in gout and causing a lot of the inflammation. Has less of an impressive response in other types of arthritis, but particularly gout, it can be as good as an NSAID.
Fantastic. And what about plaquenil, which I've always wondered about? A malaria agent. How does that work?
It's only been identified in the last 10 years, really, how it works. And it's quite complicated, but primarily it's working on aspects of the white blood cells and how they respond to antibodies and immune triggers.
Still useful?
Oh, very
Not
useful.
particularly in gout, but...
Oh, no, I mean, certainly for inflammatory arthritis, be it rheumatoid arthritis or other forms of inflammatory arthritis, it's very important. And the connective tissue diseases, lupus and other types of connective tissue disease, it's a cornerstone of treatment. And the great thing about it is that you don't need blood monitoring, it's well tolerated, less side effects than an NSAID. So for a drug that has such a good safety profile, it can be very effective.
Yeah, and finally with those drugs, where do you put in oral steroids, if at all?
Oral steroids are important, but you want to see them as a bridge to disease control. You want to put their disease into remission so there's not a need for steroids.
Yep.
So if someone presents with an acute inflammatory arthritis, it can often take 2, 3, 6, 12 months to get on top of their disease, and steroids over that time can be important. I find with patients who first present with an inflammatory arthritis that if you can get their trust and acceptance of their disease and the fact that you need treatment, that's important. If you put them on steroids and they can immediately start moving and feel improvement, then they're going to be more likely to be accepting of the medications.
So you're using it as a short-term potent anti-inflammatory over a month or so?
Yeah, until you get control with your long-term agents. And it's also been shown that, say rheumatoid arthritis, within 8 weeks on MRI, you can see erosions and damage happening. And steroids have been shown to limit that damage. So until you get control down the track, steroids in the early stage are very beneficial in both making a patient feel better and also preventing damage happening.
Whacking great dose?
Oh, no.
No? Sort of 10-ish milligrams of prednisolone?
7.5, 10 milligrams.
Yeah. Okay, so 50 is...
Oh, no. Yeah, that's overkill.
One.
Yeah, exactly.
Super.
Yeah.
Our final segment for tonight looks at pain management using opiates. We took a look at the new guideline from the WA Drug and Alcohol Office, Managing Chronic Non-Malignant Pain with Opioids, a resource kit for GPs. Dr Stefan Schug from Royal Perth Hospital spoke to us about how to apply the guidelines in your practice.
Stefan, welcome to the program.
Yes, hello, Olga.
GPs have recently received a guideline from the Health Department called Managing Chronic Non-Malignant Pain with Opioids Resource Kit for GPs.
Right.
And I understand that you were involved with the development of that kit. Could you talk us through some of the contents of the kit and some of the aims of releasing that to general practitioners?
I mean, the background is pretty much that over the last 5 to 10 years, really worldwide, there has been a possibly unnecessary and unexpected increase in the use of opioids for the treatment of chronic pain of non-malignant origin. And that is not necessarily evidence-based, as the evidence is not very good for using opioids in this condition. And there have been considerable concerns about the amounts of opioids prescribed, the amounts of opioids thereby available for diversion, and the number of patients who show drug-seeking or aberrant drug-taking behavior. And on the basis of this the health department had got a task force together to try and bring a little bit more evidence-based medicine and rationale into who should have opioids with chronic non-malignant pain.
Patients do turn up at general practices requesting opioid analgesics, often stating that they've been on these for a very long time. And sometimes in a country practice, it's very difficult to actually sort out who's prescribed it or why, or whether it's the most appropriate. And sometimes difficult to access some alternatives. So could you maybe talk us through working up a patient like that, who, say, might present taking a lot of Panadine Forte or OxyContin, and work us out on what to do instead?
I mean, first and foremost, I think if a patient presents with a history of opioid taking and wants further opioid, one of the things we are suggesting, and we have therefore developed, is this nice sign here for practices, which is actually saying that this practice is not prescribing S8 drugs on first consultation. The second tip I would recommend, and we follow that, is you ring the pharmaceutical branch of the health department and ask if this patient is on an authority for long-term opioid prescribing and who has this authority. And usually that means that only this doctor or this practice can prescribe opioids. And that gives you some ways out of actually saying, look, you get your opioids from this place and we cannot provide you additional opioids. So that's the story with patients who come and claim they are on opioids. With regard to working a patient up, this is clearly a very complex issue. I think there is a group of people who have chronic pain, but the chronic pain is based on ongoing nociceptive processes. And these are, for example, patients with cancer pain, patients with osteoarthritis, and so on. And in these patients, usually the decision to introduce opioids is relatively easy. They usually need moderate amounts of opioids, and they do very well over long periods of times. So let's say you have somebody with a hip osteoarthritis who is intolerant to NSAIDs, maybe has contraindications to NSAIDs, you're using paracetamol, it's not enough, then introducing, for example, buprenorphine patches or daily OxyContin doses of 20-40 milligrams a day will usually be extremely beneficial to these patients, and we see these patients, and 5 years later they're still on the same amount and there are no problems.
Okay, so their nociceptors are just basically loaded up with the opiate and they don't require any accelerating in dose?
I mean, it seems that anyway in opioid responsive pain, the pain is some sort of an antagonist to the development of tolerance. And we see that as well in cancer pain patients, where we don't see a lot of tolerance in palliative care. And we see it also, I think, in these patients with genuine nociceptive pains, and osteoarthritis is possibly the best example. The big problem are the patients with chronic pain syndromes, where we now think that central sensitization, neuroplastic changes of the central nervous system, which are aggravating pain or maintaining pain even though there is no significant nociceptive input. These are the patients which are a big problem.
And I think in general practice, when we view these patients, a fair number of them also seem to be either heavy drinkers or heavy smokers or heavy marijuana users. Often not terribly motivated to do anything to change.
That's right.
Where do you start?
I mean, first and foremost, I think patients who have, for example, chronic low back pain are an extremely poor group of people to use opioids. The responsiveness of chronic non-specific back pain to opioids is very close to zero. You can see that in all randomized controlled trials and meta-analyses. And for these patients, even to offer opioids, in our opinion, doesn't make a lot of sense. So these patients should be offered options such as physical activation, and I know it's hard to get patients to that, but I think by actually consistently trying to promote concepts of this type of back pain is more a lack of physical training, a weakness of supportive muscles and so on, than a real disease, I think is a very important concept here. And I think what has happened over the last, 20, 30 years is that we have over-medicalized things such as chronic low back pain and made it a disease when it is to a large extent something more like exercise intolerance.
Yeah, I think almost certainly those patients, by the time they get to you, sometimes the second or third doctor in the row, they've almost all had a CT scan, which will show degenerative change and disc bulging.
We are very strongly opposed to imaging these patients, because if it has no therapeutic consequence, then why do a CT scan, why do an MRI scan? The only thing you get is you get a terrible report, which to the patient reads as if they have a very severe disease.
Yes.
While I always tell my patients, if you would get an MRI scan of me, it would most likely look like the MRI scan of you. And if you would take 100 people off the street and do an MRI scan on them, you would get exactly the same results as from 100 chronic back pain patients. There is nothing on an X-ray or an MRI scan which can show you this patient has back pain and this patient has no back pain.
Now, the guidelines also talk about assessing and addressing mental health and substance abuse issues. How would you suggest we assess those, and how would you suggest that we address those?
I mean, first and foremost, these guidelines are suggesting that you assess them, because if you find them, you should be even more cautious about the use of opioids. And that's exactly what is in these guidelines. The idea is, if you have, and you see there on the guidelines a group of people who you better should not start on opioids without input from a multidisciplinary pain medicine center. And these are, as listed here, patients with a history of previous alcohol or drug dependence, patients with a history of previous problematic drug opioid use, patients who have significant personality disorders, and so on. Because we think that these patients should be seen by a psychiatrist or a clinical psychologist, which they can be seen in our multidisciplinary pain centers, before you initiate something which might actually make things worse instead of improving them.
And if they turn up already on the opioids, is the referral still appropriate?
Yes, absolutely. I mean, the health department, as you know, requires 12 monthly review by a specialist for ongoing opioid prescribing. And while our services are stretched simply by referring them to us, the health department acknowledges that a GP has taken the right step to solve that problem. But they might implement on the GP rules, like, for example, the opioid contract, which is in these guidelines.
Yeah, could you talk about that?
Yeah, I mean, the idea of this is more or less that there's increasing data to suggest that therapeutic contracts are helpful in actually outlining responsibilities of the partners, doctor and patient. And this is more or less a contract which is outlining your responsibility as a doctor to provide the patient with the agreed amounts, to be receptive to their problems, but also that the patient actually cannot go doctor shopping, cannot sell his drugs, cannot take drugs outside the ones you have agreed upon, cannot increase the dose without discussing it with you. And the idea of this is that if you start a patient on an opioid and you do a trial period, and we recommend that people should be on a 4 or 6 week trial period, and that's in the guidelines too. So you do a 4 to 6 week trial of a slow release opioid. And in these 4 to 6 weeks, the patient needs to achieve certain goals which you have agreed upon. And the general thinking now is that the goals are more importantly improvement of function.
So it might be something like, I will be able to go to work every day, or I'll be able to drive the truck to the next
or
town.
Starting with,
whatever.
I will be able to do my physiotherapy program because it doesn't hurt so much anymore. Or going swimming 3 times a week, or things like that. And the overall goal should clearly be more this improvement of function than relief of pain. Because there's pretty much general consensus that relief of pain without improvement of function is of no benefit to the patient. They will not gain improved quality of life. They will not lose their depression if they just get their pain from 7 out of 10 to 5 out of 10. They need to do something with the pain relief. So what we suggest is a first opioid trial with agreed goals. And if after 4 to 6 weeks these goals are not achieved, there's a very good point to say that is it. Opioids are not effective for your pain, and we have to find other avenues. But if you start this trial with a contract, then there's already awareness by the patient, and this is a patient information leaflet which comes with these guidelines, and that ends with a contract. So it explains to them what are the problems, because there are problems. Travel is not as easy if you are on a long-term opioid. People might get constipated. People might have supply problems when they forget to pick stuff up and so on. And so they need to be aware of that, but then also they need to sign that there are certain rules, and that if these rules are broken, the opioid will be tapered or discontinued.
Can you tell me about which opiate for which patient? For instance, I've even had a couple of patients with long-term osteoarthritis pain who've come back from pain clinics on methadone, which is something I'm not at all familiar with using. Is that something GPs should be considering?
There is clearly a bad taste to the word methadone, because people think methadone, drug substitution. They don't think methadone analgesic. But methadone is a very good, long-lasting analgesic. It has a very good mu receptor affinity and intrinsic activity. It has a few beneficial other effects, such as a slight NMDA receptor antagonism, which might help in neuropathic pain or wind up central sensitization, and some noradrenergic and serotonergic reuptake inhibition, which might also help in chronic pain states. From that point of view, methadone is a good drug, and it's also more or less a slow-release preparation without being in a special preparation, because it has such a long half-life that for a very cheap price, you get what otherwise in OxyContin, and so has to be achieved by complex pharmaceutical preparations. The problem with methadone is that the long half-life is totally unpredictable. And so if you get the dose wrong, then you can get very high opioid plasma concentrations with potential risk of respiratory depression. And for that reason, one needs to be very, very careful with methadone introduction, and possibly people who have never introduced a patient to methadone should stick to more conventional, conservative treatments.
Okay, so we might stick with the OxyContin or the fentanyl patches.
I mean, I think what is underestimated is possibly the value of slow-release tramadol in chronic pain. Tramadol, as you know, is not only an opioid, but has also tricyclic-like properties. And we know that tricyclic agents are very useful in neuropathic pain and chronic pain states. And for these reasons, introducing tramadol in a very slow way, and that's the problem. A lot of people say, oh my God, tramadol, I can't tolerate that. If you start patients on 50 milligrams tramadol slow release, maybe at night first, then twice daily, and then build it up, you can achieve very interesting effects in a lot of patients, including, for example, patients with fibromyalgia. And you have the advantage that abuse of tramadol is rare, and the black market value is close to zero. So that's one option. Then clearly a lot of patients do very well with the new buprenorphine patches. And again, it's a nice way of introducing an opioid because they're very weak, and in particular in elderly patients, you start with a 5 microgram per hour patch and achieve very good effects, for example, in osteoarthritis. And then clearly there is the OxyContin, the transdermal fentanyl, and maybe MS-Contin, and the new hydromorphone slow release, which are other alternatives.
And we can always consult a pain service if we're having a problem.
I have no problem with people ringing, and we are trying to advise them on the phone. And a lot of problems can be solved on the phone instead of the patient having to travel a few 100 or 1,000 kilometers and waiting 10 months before they are seen.
That's great. Stefan, thanks for joining us.
No problem. Thank you for coming.
Thanks to Dr. Schug for that, and if you want more information about the resource, you can find it at the Drug and Alcohol Health website. That's about it for this broadcast. Can I ask you, Andrew, as one of the 30% for whom the placebo effect of glucosamine works, any final thoughts for our GPs? Or for me?
Well, if you can afford it and you think it works, then keep taking it. It's unlikely to do you any harm. The main messages I'd have is always think about the diagnosis. Don't just accept pain as a diagnosis. Pain's not a diagnosis. You think of the diagnosis, what's causing their joint pain, early diagnosis, the inflammatory joint problems you've got to recognise, diagnose early and treat early.
Yeah. And you'd agree with that, Olga?
I would.
Yeah.
Yeah.
All right.
Including inflamed osteoarthritis, which can be just as painful. For
Exactly.
You just you need to get on top of it fast.
Yep, that's right.
Andrew, thanks for being with us tonight. We really appreciate it.
It's been a pleasure.
Dr. Andrew Taylor. Now, before we leave you tonight, some of you may be interested to know that in June's issue of Check, there is a good set of questions on rheumatoid arthritis and juvenile arthritis that you may wish to tackle while the programme is still fresh in your mind. And do remember, if you want to review this programme or any of our previous programmes, you can do so by simply visiting our website, which is www.ruralhealthwest.com.au, and you can watch the programmes live or download them as a video or audio podcast. We're back again on the 3rd of August with a programme that will focus on haematology. Thanks for taking the time to join us. From Dr. Olga Ward and myself, Jerry Gannon, good night, and thanks for being with us.